So, all right. So I just wanted to take some time to kind of review what we do in our clinics. And I think the biggest kind of addition that we can help with, I guess, is with testing and management of common allergic diseases. So that's what I kind of wanted to give an overview about. There's lots of different types of allergic reactions, and I'm sure you've probably studied many of these kind of during your initial medical school training, and you've probably seen some of this in your rotations, but the way different allergens kind of present themselves to the different systems in the body really determines what type of reaction and outcome you're going to see. But with skin contact, the most common kind of allergens we tend to see in practice are poisonous plants, poison ivy is probably the most common, animal scratches, pollen, latex allergies. With injections, we see bee stings and other type of venom stings too, like yellow jacket, hornet, wasps, and so on. For ingestions, medications and foods are probably the most common. And then for inhalation, allergies, pollens, dust, mold, and animal dander is the most common. You may have seen a diagram like this before, or you will see it sometime in the future, but the different types of hypersensitivity reactions are categorized in 4 different models. The first one is probably the most common that we see in our practice. It's IgE mediated hypersensitivity, and common manifestation include anaphylaxis, which is a severe allergic reaction, hay fever, which is allergic rhinitis, which is nasal, eye, sinus, eye, ear allergies, most commonly due to pollens and animal dander and dust mites, and we'll go over that in a bit. Asthma, hives or urticaria, food allergies, and eczema as well. So this is probably the bulk of what we see in practice, these types of reactions. Type 2 is IgG mediated cytotoxics. Hypersensitivity and common manifestations are blood transfusion reactions, erythroblastosis vitalis, and autoimmune hemolytic anemia, which you're going to see probably more often in the hospital than you are in the clinic setting. Type 3 is immune complex mediated hypersensitivity, and that includes Arthus reactions, serum sickness, necrotizing vasculitis, glomerulonephritis, rheumatoid arthritis, and lupus. And again, we don't tend to see this as often in clinic either. Type 4 is cell-mediated hypersensitivity, like contact dermatitis, which we see quite often. And then rejection as well. The type of allergy testing, the most common types of allergy testing we do in practice include skin testing, blood testing, for serum IgE to aeroallergens. That's probably the most common, but we certainly do it for not only environmental allergies, but food allergy and drug allergy as well. And these are the type 1 type of reaction, like we were talking about, they're IgE mediated reactions. The other type of testing that's more common in our practice is patch test. And what that looks for is the type 4 hypersensitivity reactions, looking for allergic contact dermatitis. Have you all ever seen skin prick testing? Yeah, okay. So for environmental allergies, skin prick testing, the sensitivity and specificity are around 80 to 85%. So it's pretty high. For food allergies, skin prick testing is generally quite sensitive. It's around 70% with high, but you do have high rates of false positives. And then the caveat with this type of testing is that you have to hold antihistamines a week before testing. So we prefer doing skin prick testing for environmental allergy and food allergy and medication allergies. But there are certain types of patients that we can't do this type of testing for. If they're unable to hold antihistamines for whatever reason, or if their skin is just very, very sensitive and it's hard to interpret the results, those are probably common reasons why we can't do skin testing for some of our patients when we first see them. What it actually looks like, this is a kind of diagram explaining that, but basically you take a suspected allergen, you put it on the skin, and then you take it looks like a plastic toothpick with a sharp end, and you just scratch the top layer of the skin with the liquid allergen. And we put a negative and a positive control on the skin to know what a negative should look like, what a positive should look like. And then we compare those two results to the different allergens that we're testing for. And depending on the wheel and the flare, meaning the size of the elevation of the skin and the redness around it, that kind of gives us a better idea of what positive results are and what negative results are. The other type of skin testing we have in office is called intradermal skin test, which you guys have probably seen and done because you do that for TB skin testing. So it's performed with 100 to 1,000-fold dilution of the skin prick concentration. So it's quite diluted compared to the scratch test that I just described. It is more sensitive, but it's less specific than the skin prick testing. So you tend to have high false positive rates. We do use it in practice for environmental allergies, and when I say environmental allergies, I mean pollens, dust mites, animal dander, cockroach, moles, things in the environment or air that can really disturb, whether it's nose, sinuses, eyes, ears, mouth, throat, skin, and even lungs for some patients. Venom hypersensitivity, we do use ID testing for, and that includes the stinging insect allergy, for example, honeybee allergy or wasp or yellow jacket or hornet, and so on. For drug hypersensitivity, we do use intradermal testing as well, and penicillin is the most common type of drug hypersensitivity testing that we do in clinic. In larger practices or academic centers, they tend to have more options in terms of what medications they can test for, but penicillin is the most well-known and the best studied, and most practices will have penicillin testing available to them. Intradermal testing is not used in the diagnosis of food or latex allergy due to high rates of systemic reactions. So we don't do it for those reasons. Systemic reactions are uncommon, but as you can see, they do happen, and it's anywhere between less than 0.02 to 3.6%, but fatality is exceedingly rare. So whenever I'm educating patients on what type of testing we're doing, and if it happens to be skin testing, I always preface before doing testing to say, hey, this is how the testing is going to go. We expect local kind of symptoms on your skin, but if you have any symptoms beyond that, for example, sneezing or coughing or trouble breathing, to let us know, because on a rare occasion, even during skin testing, some patients can have a severe allergic reaction and need care for anaphylaxis in clinic, and sometimes beyond the clinic as well. Sometimes I've had probably 1 or 2 cases during practice where I've had to send patients to the hospital because they've had such a severe reaction where we couldn't take care of it in the clinic. We do our best to take care of it in the clinic, but sometimes it's out of our hands, unfortunately. Generally, it's not common. Most people just feel local kind of itchiness and swelling where we're doing the testing, and that goes away after the test is done, after we clean it off. This is what intradermal allergy testing looks like. We take a small needle, make a little bubble underneath the skin, and I know you've seen and done this before, so you kind of know what that looks like. In terms of blood work, when we use serum IgE to aeroallergens, and you may have seen this, I don't know if you've had patients where you've seen serum IgE for different allergens, but generally it's less sensitive than skin prick testing. So it's not my go-to kind of test, but in the right clinical setting, it is preferred sometimes. Sensitivity ranges between 60 to 95%, and specificity ranges between 30 to 95%. it is helpful in the following situations, like I was saying earlier, when antihistamines can't be stopped and we're not able to do skin testing. I've had patients, for example, be on hydroxyzine and they just cannot stop it. That would be a great patient to do ceramide allergens, for example. If they've recently had anaphylaxis, sometimes you can have false negatives on skin testing. So if I see a patient with anaphylaxis and I want to do skin testing, generally I have them come back in a month or month and a half to do skin testing. So they've had enough time since their last reaction where the skin test is going to be reliable. But if we're not able to do that for whatever reason, this is an option as well. If they have poor pulmonary function tests, for example, if I'm seeing a severe asthmatic, generally we don't like to do skin testing for uncontrolled asthma because that rare risk of having severe allergic reactions to skin testing, if that happens in a severe asthmatic, then it's hard to control. So generally we don't do skin testing if we have an asthma patient that's not well controlled. Generally we want their studies to look pretty normal or a lot better before we kind of go down that road. But if we're not able to control them, they have severe asthma, they're uncontrolled, they're having exacerbations all the time, then this is the type of test that I prefer. Another type of patient that this would be really good for would be for severe eczema. Sometimes it's just hard to have any patches of skin where you can actually do skin testing because their skin is covered with eczema, and that would be a really good candidate for blood work instead. If a patient is dermatographic and their skin is just very, very sensitive, if you ever scratch, I have patients kind of just scratch themselves, or I can take a tongue depressor and just lightly rub their skin. And if that gets to be red and raised, I know their skin is quite sensitive, and doing the skin testing is not going to be helpful because it's going to be hard to interpret the results. And again, those would be really good candidates for blood work as well. If they're highly sensitive patients, or if they have major food allergens in children, on a rare occasion, if I have a child that's just very allergic to peanut, for example, and they've recently had a reaction, and if contact on their skin is quite severe for them, again, that would be a really good candidate for having them do blood work instead of skin testing as well. So patch testing is something I mentioned earlier. It's a type of test we do to evaluate for allergic contact dermatitis. And it's done very differently than the skin testing that I just described earlier for environmental allergies and drug allergies and venom allergies as well. The way patch testing goes is generally we have, well, it depends on your practice, but the idea is you have large stickers, and this is kind of a sample of this company makes like the common ingredients that are tested for, and it's quite expensive, so not all practices have this. Some practices make their own and it's more cost effective, but the idea is you have a long list of ingredients that you test for, and each of these squares on the patches are testing for different ingredients that are commonly in skincare products, metals, things that contact the skin, that touch the skin, that sometimes can cause the skin to have delayed itchy rashes. And the common kind of ingredients that are being tested in here are generally in skincare products like lotions, creams, soaps, cosmetics, jewelry, topical antibiotics, topical medications, adhesives, again, things that touch your skin that can cause you to break out in itchy rashes. And it's very hard to diagnose properly because sometimes, people will change a product or change many products, and it's hard to really identify which product they're having rashes from. And the patch test can kind of help us get a better answer as to why things are happening. The way we do the patch test is, again, it's very different than the skin testing earlier I described. We put the stickers on the back, usually the upper back. Again, whether it's square or circle, each of these circles, or if it happened to be that other type of patch test would be squares, each of these individual wells would test for different ingredients. We would put the stickers on the back and we outline it because we want to know exactly how they were located. So when we go to read it, it's a bit easier to locate where each of these allergens were. We actually have patients keep those big stickers on their back for a couple of days, and then we have them come back for the first reading. These are examples of what the readings may look like. We do a second reading 2 days later, because what we're looking for is a delayed reaction on the skin. If it's going to be positive, generally, if it's a weak positive, you'll see some redness. You may see a little bit of papules. Once it gets to be a strong positive, you see more erythema, you see more papules. You may even see a little, it's hard to see in the picture, but you may see tiny vesicles in there too. And if it's extremely positive, you're going to see a large bulla or vesicles coalescing together. Sometimes you can have some doubtful or irritant reactions too, and doubtful is going to show very faint or homogeneous erythema and no infiltration. And irritant is going to show discrete patchy erythema, but there's not going to be infiltration. So you don't actually see the demarcation with these as you do in the positive settings. So I know we've touched on these a little bit earlier when we were talking about testing, but the common diagnoses that we tend to see, again, are chronic rhinosinusitis, asthma, atopic dermatitis, which is eczema, food allergy, drug allergy, vaccine allergy, and contact dermatitis. There's a long list of other things, but these are the more common ones. I'm sure you've seen patients with asthma, or you will be very soon, depending on where you are in training. But generally, the way we diagnose asthma, depending on the age of the patient, it kind of depends too, but we have lots of different types of pulmonary function tests. The ones we tend to do in clinic include spirometry. Sometimes we'll do baseline spirometry. We'll give a breathing treatment with albuterol, and then we'll do the spirometry again to see if there's actually reversibility. In the different kind of parameters that we're looking at, we can also do methacholine challenge tests in the office, which rules out asthma. If there's any question about whether, if we're inclined to say that it may not be asthma, that's a really good test to kind of rule it out. For young children, I tend to do exercise challenges because it's hard for them to actually do spirometry properly, or even peak flow sometimes. And if exercise is a trigger, then we basically make them run in the clinic. We have treadmills in the office as well. We get their heart rate up to a certain level, and then we actually give them time to rest. And then we follow along their peak flows or symptoms, depending on how young they are, to see if there's any changes with that. And if it drops to a certain level, that can be really helpful in identifying exercise-induced asthma. Some offices do have phenos, which is kind of checking levels of nitric oxide. It's not very, very specific, but sometimes if it's elevated, can be helpful in identifying exacerbations in asthma and even allergic rhinitis sometimes. Treatment for asthma, there's many different types, but avoidance of triggers is a big one, and common triggers for our types of patients types of asthma patients tend to be infections, cold air, smoke, environmental allergies. I just had a patient that I did testing for cat and dog. They were positive and they have asthma. And it would not surprise me, and dust mites as well. It would not surprise me if some of those are actually contributing to her asthma at this point, and she just doesn't know it. And this is quite common in our patients, that they have environmental allergies and asthma. And when their environmental allergies get worse, sometimes their asthma gets worse too. Those are probably the more common triggers. Certainly there's a predisposition genetic factor in allergy and asthma as well. And we tend to see multiple family members for that reason. You know, some family members may have asthma, others may have environmental allergies and asthma or medication allergy. So we do see lots of different members in families because of that. There's lots of different medication options. We have lots of different inhalers. That's probably our go-to for asthma, medical treatment for asthma, but we do have Singular, which is Montelukast. It's a tablet that we use. It's for some patients, it works really well. For some people, it doesn't work at all. There are some side effects that I always ask patients to kind of watch out for, but those are probably our kind of go-to types of medications for asthma. And certainly if they have environmental allergies, allergy shots and medications to control the environmental allergies is really important to discuss as well. If I have patients that are very hard to control with medications and avoidance of triggers, then I start talking with them about our different biologic options. There's lots of different biologics on the market now, but the more common ones we use in practice are Xolair, Fasenra, Dupixent, Nucala, and they're really good medications. They're quite expensive, and it's hard to get authorization, but for the right type of patient that's not well controlled with our typical kind of treatments, they're really good options for those types of patients. We tend to share a lot of patients with pulmonary because they see asthma as well. And sometimes there's overlap of asthma and COPD as well. So there's definitely overlap in our patients with some other types of subspecialties as well. Atopic dermatitis is a very common diagnosis we see. It generally presents early in age. We usually see a lot of children with eczema, and as they get older, they tend to outgrow it. That's been the case for a long time. But I do have some patients that have never had eczema and then they just develop it later in life. I have seen that as well. But the typical kind of scenario is you'll see it in childhood and it does improve over time. The way the diagnosis is made is really by exam and history. And again, there's a genetic predisposition. Sometimes if the eczema is really hard to control, or if the history kind of points us in this direction, we may do testing for possible triggers. So if I have a young patient whose eczema has been really hard to control, if they have an animal at home, for example, I may test them for cat and dog dander or dust mites. If I have a young patient with eczema and the mom is really concerned that, hey, every time we feed our child, let's say milk, the eczema gets worse. In that type of setting, we may do food testing as well. I've had some patients that have had, I'll give you some examples because I think it helps to get examples and put things in perspective. So I've had some patients that have had really severe hand dermatitis, and it's just been really, really hard to control. Sometimes they've seen dermatology and they've been told it's eczema, and they come to us and obviously we do the standard things that we do for eczema, but sometimes I'll think about doing patch testing, because sometimes if if a patient not only has eczema, but they're applying something that their skin just does not like, then it's really hard to control that eczema because we're continually applying something that's triggering the eczema to flare. So not only are we seeing eczema on the hands, but we're also seeing allergic contact dermatitis. So we kind of have to treat both to get the best kind of outcome for that patient. So sometimes we'll do patch testing in that setting as well. In terms of treatment, again, avoidance of triggers are kind of our mainstay for a lot of our allergic diseases. So if there's a food trigger or an environmental trigger or a contact trigger, we'll remove those, and then we'll really discuss about what our options are for medical treatment. I think for eczema, it's very important to take time into discussing skincare management, because part of the issue is, it's a very cyclical kind of issue with eczema. You have dry, itchy skin and you scratch and it tends to rash. And the more that continues, the more the eczema tends to flare. So we kind of have to manage several of these things to really get good outcomes. So we talk about doing wet wrap sometimes because the skin is just very, very dry and it needs to be hydrated. Daily baths is something we recommend. Moisturizing quite often is something we recommend. And I'll give them, if I have samples of moisturizing creams, I'll give them options on, what type of skincare products are out on the market that are easily accessible, that are better than some of the other ones. Because typically when I ask about what soap and moisturizing cream people are using, a lot of times people are using Bath and Body Works and it smells great, but it makes the skin really, really uncomfortable, and it's not very moisturizing. So kind of going over what we're using on the skin is very, very important as well. And then certainly topical steroids and other topical treatments are very important to kind of review, and how often you should use that and what the side effect kind of looks like and what to watch out for is very important. For very uncontrolled eczema, we do have a biologic on the market that we use called Dupixent, and it works quite well for the right patient. Obviously, it's not right for everybody. I think for most people, taking care of the dry skin, the itchiness, avoiding the allergens, and then topical medications are enough to kind of keep things controlled. But in the right setting, Dupixent is a good treatment option that we have for very uncontrolled eczema as well. Chronic rhinosinusitis, again, it's probably one of the most common diagnoses we see, and we see it in all ages. Chattanooga is regionally, it's like we just have a lot of pollens here, and the way geographically we're situated, everything kind of settles. And I've had lots of patients say, I was fine in Florida and I moved here and now I feel miserable. What's going on? This is a very common story that I hear in patients, and rightly so. I think environmental allergies are quite severe here for a lot of our patients. The way we diagnose this is really with the test that I was describing earlier. We do skin testing to aeroallergens, we do intradermal testing to aeroallergens. And if we're not able to do those, then we'll do serum IgE to aeroallergens. Once we diagnose it, the way to treat this is, again, we spend a lot of time talking about, educating about how to avoid what you're allergic to. So if I have a patient come in, that has a cat at home and they're allergic to their cat, we'll talk about what are the things you can do. Obviously, I always preface by saying, if ideally you wouldn't have a cat, but I'm assuming you're going to keep it. And if you are, these are the things you can do around the house that will help you to not be so symptomatic. And I think that's very important to do, because if you're not doing the avoidance measures, then, medications and treatments will get you only so far. So I think it's a very good and important component in terms of treating this disease. We have lots of medical treatment options, but our main typical things that we try are nasal steroid sprays. We have lots of other nasal sprays too, like nasal antihistamines, oral antihistamines. Singular is another option that we try out for some of our patients. And sometimes we have to use a combination of these to get a good outcome. And then we do offer allergy shots, which is immunotherapy. Not everybody decides to do allergy shots, and not everybody is a good candidate for it. But I think in the right setting, for example, the patient with the cat that's cat allergic, that would be the perfect patient to be on allergy shots, because it can make a tremendous difference in a patient's quality of life. And a lot of our patients, especially environmental allergies and asthma, they're normal. They feel a certain way for so long, it's hard for them to know how well they can feel until they start feeling that way. And I see this in a lot of our patients. I have patients that come back after doing shots, and I've had patients say, I wish I had done this a decade ago. I wish I had done it sooner because I feel so much better. They work really well, but it's a very slow, long process. Generally, when we start allergy shots, it's a 3 to 5 year commitment. So it's a very slow process. And the first year is the slowest. Generally, we have patients come in once a week and we slowly build up. The second year is every 2 weeks, and eventually you come once a month. So it is less often as you go along. But the idea is over time, your body gets used to seeing what you're allergic to. So when you do encounter cat allergen or pollen allergens, your body's not so reactive, so you feel better, you have less symptoms, and you need less medications. And if patients have a history of recurrent sinus infections, ear infections, asthma exacerbations, or eczema flares because of environmental allergies, all of that gets better too with allergy shots. So it's definitely a very good treatment for the right patient. Food allergy is another diagnosis that we see quite often. And typically the way we diagnose, obviously history is a very important component of diagnosing food allergy. And there's lots of food reactions out there. Not all of them are IgE mediated food allergies. But if the history is consistent or points us towards this diagnosis, we can confirm it by doing skin prick testing for foods. We don't do intradermal to foods due to risk of systemic reaction. And if we're not able to do skin prick testing, or if there's another reason, then we may decide to do serum IgE. I'm sorry, I meant to foods. I don't know what that says there. So we can do skin prick testing, or serum IgE to foods as well. In terms of treatment options for foods, it's really by avoidance of that food. And again, we spend a lot of time talking about how to avoid eating the food that patients are allergic to, and how to identify that food in different types of meals, how to read labels. I think that's probably the hardest thing for patients, because not everything is labeled so well when you're going out to eat, or if you're buying something that's not prepackaged. I've had patients, the times that I think the more common things that I've had patients kind of say have had accidental exposures to have been, foods that have been shared. So for example, a child with peanut allergy knows to avoid peanut, but they got a cookie from a friend and the friend wasn't able to verify if it had peanut or not. And the patient ate it and had a reaction. It's not that the patient didn't know that they had to avoid peanut. They just didn't know exactly what was in the food, and they assumed that their friend would know, but they didn't. So that's a common scenario of accidental ingestions. We always prescribe EpiPens, and there's different companies that make epinephrine auto injections. EpiPen is probably the most commonly known in the market, but there's generic versions of epinephrine. Auvi-Q makes it, but certainly they need to have epinephrine auto injectors of some kind, and always carry 2 with them at all times, because and it's very important we do a lot of teaching in terms of how to carry it, how to administer it, when to administer it. And I always advise patients that if they ever use epinephrine of any kind, that they do need to call 911. And I always have patients carry 2 epinephrine auto injections, because sometimes you can have symptoms or reactions even after the initial one. So it's always important to carry 2 for that reason. The only food allergy that we have kind of a treatment plan where we can actually treat the food allergy. There's a new product called Palforzia for peanut allergic patients. And there's an age kind of cutoff, but for children that have a history of peanut allergy, that's been diagnosed, it is a treatment option where the idea is that you don't get rid of the peanut allergy, but the idea is after you've been on treatment, the risk of accidental ingestion of peanut and then having anaphylaxis, that chance of anaphylaxis decreases with accidental ingestion. So it's not like you're getting rid of the peanut allergy, but it keeps you safe if you were to happen to get into contact with a small amount of peanut. That's the only FDA approved kind of treatment we have for a food allergy at this point. There are definitely clinical trials and in private practices and academic centers going on, but that's the only approved one thus far. For drug allergy, we do have testing, and it is useful for penicillins, chemotherapeutic agents, muscle relaxants, insulin, and heparin. We do have skin testing for those things, but in private practice, penicillin is really the one that we have, and we do have it for anesthetics as well. So value of drug skin testing to other agents is variable. Patients may be allergic to a metabolite. There's lack of standardization, and there can be non-IgE mediated mechanisms that may be involved. The way we diagnose, for example, penicillin testing, we do skin prick testing, we do intradermal skin testing. If those two are negative and the history, of course, supports a history of penicillin allergy, then we'll do a drug challenge in the office to confirm that they're not allergic to penicillin anymore. That's the way we kind of diagnose it. If skin prick testing or intradermal testing for penicillin is positive, we stop there and we don't go any further, and we say, hey, you're still allergic to penicillin. We don't do serum IgE to drugs. What I will say is, if you do see patients with a history of penicillin allergy as a child, I would consider sending them to an allergy clinic of some kind. And the reason why I say this is most people, if they've had an immediate reaction to penicillin, let's say they got penicillin and they had a rash soon after getting penicillin. If you have a patient like that had this reaction more than 10 years ago, it was a long time ago, or they didn't remember exactly what happened, they weren't hospitalized, they didn't have any blistering rashes or Steven Johnson, anything, delayed like that. If it sounds like an immediate reaction, if it's been more than 10 years, more than likely they've probably outgrown their penicillin allergy. If I want to say more than 90% outgrow after 10 years if it's an immediate reaction to penicillin. So if you've had a patient, because I see this a lot, and you're going to see this a lot. If you have patients that you want to give penicillins to, but they said, oh no, my mom said I was 5 years old and I had a penicillin allergy and I've not had it anytime since then, and I'm an adult right now. This is the perfect person to get penicillin allergy testing, because we can verify, hey, you're not allergic, or you still are. But if you're not allergic, then you're open to having penicillins in the future. And that opens a lot of options in terms of antibiotics for those patients. So those patients would be really good to refer to allergy clinic to do testing and verify. These are some examples of contact dermatitis, allergic contact dermatitis. And this is a picture of someone who's had a belly piercing that has metal in it, and they're having redness and rash around that area. So this is a reaction to metal, to a belly button ring. Here it's to an earring. Here it's to a belt buckle or pant exposure. These are just common kind of scenarios for metal allergy. We talked about patch testing earlier. So again, metal, sometimes you'll see patients that have had implants of some kind. For example, I've had patients come in to say, hey, I had a knee transplant, like knee implant years ago, and I've had issues around that knee. I want to be tested for the products that were used or the metal that was used. That's something that we can kind of help answer with patch testing. We talked about hand dermatitis and how we can kind of diagnose if they're using certain topical, products that may be causing their dermatitis to be worse. If you have an uncontrolled eczema, again, this is a really good testing for those types of patients. And the treatment of choice really is avoidance of the allergen if we can identify it. The other thing I would say is oral dermatitis around the lips is something that I've seen with lip products sometimes, or around the eyes is a very common area that I tend to see dermatitis. And sometimes it can be from shampoos or cosmetics or skincare products, or even nail products sometimes. Hair dye. I've had patients that have had dermatitis in their scalp because they've been dyeing their hair and the dye has an ingredient that they're allergic to. So those are common scenarios. But again, identifying the trigger and then avoiding that trigger is probably our mainstay treatment. Sometimes you do have to prescribe antihistamines or topical steroids to help with the acute symptoms as well. And if it's really severe, sometimes oral steroids. So that is it for today. Thank you guys so much for your time and attention. And please feel free to reach out to me if you have any questions about any allergic disorders or allergy immunology. Thanks.
Awesome. Thank you so much.
Yeah, absolutely. Y'all have a good day. Do y'all have any questions, by the way?
I don't think we have any questions. Thank you so much.
Absolutely. Have a good day. Thank you.